This is part 2 of our series of lectures on adrenoceptor activating and other sympathomimetic drugs. And in this video, we are going to focus on the non-selective adrenergic agonist.
Adrenergic agonists fall into two major chemical classes, that is catecholamines and non-catecholamines. Catecholamine is an organic compound that has a catechol, which is basically a benzene ring with two hydroxyl side groups, intermediate ethyl chain, and terminal amine group. On the other hand, non-catecholamine have similar backbone structure but without those two hydroxyl groups on adjacent carbons on benzene ring, thus the name non-catecholamine. Now, the structural differences create three main differences in properties between catecholamines and non-catecholamines. First, oral usability. Second, duration of action. And third, central nervous system penetration. So let's briefly talk about how they compare in terms of oral usability. Catecholamines are completely ineffective when given orally, as they are quickly metabolized by catechol or methyltransferase and monoamine oxidase enzymes in the gut, liver, central nervous system, and even inside the neurons. Furthermore, hydroxyl groups on the catechol portion make the whole molecule polar, which results in poor penetration into the central nervous system. Now, on the other hand, we have non-catecholamines, which lack the catechol hydroxyl groups. And because of that, there are not a good substrate of catechol or methyltransferase, and they are metabolized by monoamine oxidase very slowly. As a result, non-catecholamine can be given orally, and they have a much longer duration of action, and because they are less polar, they are also able to penetrate into the central nervous system fairly well. There are three types of adrenergic agonists, and the classification of these sympathomimetic drugs are based on their mechanism of action. The first class is the direct acting agonist, and of course, as the name suggests, the drugs act directly or directly activate the alpha or beta receptors, thus producing effects that are similar to those that occur following stimulation of sympathetic nerves or the release of hormone epinephrine from the adrenal medulla. The second class is the indirect acting agonist. And basically, this group of drugs, what they do is that it increases the release of norepinephrine into the synaptic cleft, or they prevent the reuptake mechanism of norepinephrine, both of which consequently result in the increase of norepinephrine concentration in the synaptic cleft and thus activation of more adrenergic receptors. Last but not least, we have the mixed action or mixed acting agonists. Some agonists have the capacity to both stimulate adrenergic receptors directly as well as to release norepinephrine from the adrenergic neurons.
By the end of this lecture, you should be able to discuss the non-selective adrenergic agonist in terms of its mechanism of action, pharmacological effects, and clinical uses.
Let us now take a look at some examples of commonly used direct-acting agonists, and we'll start, of course, with the non-selective adrenergic receptor agonists. These agents, they produce their effect by binding to alpha and beta receptors and thus mimic the actions of epinephrine and norepinephrine that naturally occurs in our body. Speaking of epinephrine and norepinephrine, keep in mind that they are non-selective, meaning that they can act on both alpha and beta receptors. They are also catecholamines, which means that their main route of administration is by injection. One of the most commonly used direct-acting agonists in clinical practice is epinephrine. Epinephrine is mostly a beta 1 and has some beta 2 adrenergic agonist effect. It also has dose-dependent alpha 1 effects. At low doses, epinephrine's main pharmacological effect is causing an increase in cardiac output. The reason for this is that epinephrine at these low doses has greater activity at the beta receptors than alpha receptors, and in this case, the effect on beta 1 receptor causes an increase in cardiac contractility and also increases heart rate. While the effect on beta 2 receptor will cause some vasodilation, this is cancelled out by the small effect on vasoconstriction by stimulation of alpha 1 receptors at these low doses. So at low doses, the effect of epinephrine on the human body mainly causes an increase in cardiac output and can potentially cause variable effects on vascular resistance. At higher doses, the effect of epinephrine on alpha 1 receptors predominates, and the amount of alpha 1 effects on vasoconstriction will overwhelm the vasodilatory effects caused by the stimulation of beta 2 receptors. And keep in mind that at these high doses, the effects are secondary to the stimulation of beta receptor, which still occurs. So you will get an increase in your cardiac output. Putting all this together, there is a net increase in vascular resistance and blood pressure at higher doses of epinephrine along with increases in cardiac output. Epinephrine can activate almost all adrenergic receptors, and because of that, it is a treatment of choice for anaphylactic shock. So activation of alpha 1 receptors by epinephrine leads to vasoconstriction, which in turn increases blood pressure, thus relieving shock. Next, activation of cardiac beta 1 receptor leads to an increase in cardiac output, which is why epinephrine is also used to restore cardiac function in patients experiencing cardiac arrest. The activation of beta 2 receptors in the lungs leads to bronchodilation, which is why epinephrine is sometimes used for emergency treatment of respiratory conditions such as asthma. Epinephrine is also used to prolong action of localized anesthetics as well as to control localized bleeding, and this is because of its vasoconstrictive property. One of the things that you should remember about epinephrine is that it cannot be given by oral administration, or it is ineffective after oral administration. And why? This is because epinephrine is a catecholamine, which is rapidly metabolized in the GI mucosa as well as the liver, which is rich in catechol or methyltransferase as well as monoamine oxidase enzymes. And as such, it is necessary for epinephrine to be given by injections. The use of large doses or the accidental rapid intravenous injection of epinephrine may result in cerebral hemorrhage due to the sharp increase in blood pressure. Ventricular arrhythmia may follow the drug's administration, and epinephrine may induce angina in patients with coronary artery disease. So these are the things that you should be thinking about when a patient is put on epinephrine. Another example of commonly used non-selective adrenergic agonist is norepinephrine. Norepinephrine is an alpha and beta 1 agonist. Norepinephrine exerts its effects by acting on alpha receptors to cause vasoconstriction. It also acts on beta 1 receptors to increase cardiac contractility and as a result will increase stroke volume. Remember that the action of norepinephrine on beta 1 receptors can also cause an increase in heart rate. But because of the intense phase of constriction caused by the action of alpha 1 receptors, you can see a reflex bradycardia. As a result, the direct effects of norepinephrine on chronotropy is cancelled out and the heart rate will remain the same.
One of the few therapeutic indications for norepinephrine is in the management of hypotensive shock. So what is hypotensive shock? It is basically low blood pressure that leads to inadequate perfusion of body tissue. So this begins at the cellular level and if left untreated can result in death of tissue, organs and organ system. Norepinephrine is actually very similar to epinephrine. However, unlike epinephrine at the therapeutic doses, norepinephrine mainly stimulates alpha-1 receptors, which leads to profound vasoconstriction and ultimately the increased blood pressure due to the increase in total peripheral resistance. The other use of norepinephrine is in the management of cardiac arrest through its agonist effect on beta-1 receptor. Norepinephrine has almost no beta-2 activity, which is why it has more limited clinical use in comparison to epinephrine.
Norepinephrine, just like epinephrine, is ineffective if given orally, and this is because it is a catecholamine and thereby would be rapidly inactivated by the actions of catechol or methyltransferase and monoamine oxidase enzymes. Excessive doses of norepinephrine can cause severe hypertension. In the past 10 minutes or so, I've given you an overview of the commonly used non-selective adrenergic agonists, epinephrine and norepinephrine. Head over to the next video on the playlist and we are going to look at the selective adrenergic agonist.